guys tell me. I've done her cardiovascular with the exception of pulses, okay? And I need to do her abdominal assessment. Would you prefer me to do the abdominal assessment next, or go and do the extremities?
Abdominal.
Abdominal, okay. So let's go back to our 4 pillars of assessment. So we have what? Inspection first, okay? What they say is the person should be lying flat, roughly about a 15-degree angle, with their knees slightly bent, okay? That's just been shown to be the best way to inspect the abdomen. So we start off with inspection. So what are we going to be inspecting for?
Distension.
Okay, the most important thing you're inspecting is for distension, okay? Distension could mean that the person has an acute abdomen. Have you heard that term used before? Acute abdomen. That refers to a very serious GI disorder. It could be peritonitis, it could be appendicitis, it could be an obstruction. It's an acute situation, okay? So I'm assessing for distension, okay? What else am I assessing for?
It's not being equal, honestly.
What, ma'am?
Like it being more...
Okay, is it symmetrical? Is it symmetrical? I'm with you on that. Does she have any scars? Okay. Does she have any herniations? Any herniations? Okay. Does she have any varicosities? What do I mean by varicosities?
Like blood vessels.
Yeah, engorged blood vessels. Does anybody get to see that? You guys went up to what, the 5th floor? There's a lot of GI stuff, a lot of cirrhosis. So what did you see with cirrhosis? Ascites, and you may see a lot of varicosities with those types of patients, okay? Good. So that's inspection. The most important thing on inspection is determining is the abdomen distended or flat. Most important thing, okay? What do we do next? Okay? So auscultation. So I'm going to auscultate, and you can do that with the diaphragm. You don't have to do it with the bell. Okay? And you're going to, and I usually start in the right lower quadrant and work clockwise. Okay? And what are we listening for?
Vowel sounds.
Vowel sounds, okay? You know, are they hypoactive, normal active, or hyperactive? Are they absent? Okay? How long do you have to listen to say that the person actually has absent vowel sounds, technically? They say 5 minutes per quadrant, okay? Which means it takes you 20 minutes. Is that actually done in the real world? No, not really. I'll be honest with you. But when you get really skilled as a clinician, you'll know when that person seriously has absent vowel sounds, okay? The other thing you can do in terms of auscultation is we can auscultate for a bruit in the midline here, right here at the epigastrum. If they have a bruit sound, what do you think that could indicate? Could be an aneurysm, an abdominal aortic aneurysm. Okay. We can also listen on the sides here and here of the midline for any bruits as well that can indicate renal artery stenosis. Okay. So you can listen for those as well. Okay. So look, listen. Now that we have it. So we can palpate. Okay. We can also percuss, but let's palpate first. When you palpate, you can actually do light palpation and deep palpation. Light palpation, you just take one hand and you're going to palpate all around her abdomen, okay? What are we palpating for? What's the most important thing?
Rigidity.
Okay, rigidity. Is the abdomen soft or rigid? Meaning hard, okay? If it's rigid, that's not a good thing. That can indicate, again, an acute abdomen. It's a bad thing. What else are you assessing for?
Tenderness.
Tenderness. So you're looking at her face to see if we are eliciting any tenderness. Is she guarded? What does that mean? Like say I go to try to touch her abdomen, she says no. That is guarding, okay? A lot of times that's a sign of peritonitis, okay? So not a good thing, right? We can also do deep palpation. Deep palpation involves using 2 hands, and we actually press firmly in those areas, and we're really determining is there any enlargement in organ size, okay? We call it organomegalia. You know, you can have hepatomegalia. What is hepatomegalia? Enlargement of the liver. Splenomegalia, which is enlargement of the spleen. You can even do, and I'm not going to expect you to do this for purposes of checkoff, but there's something called a hook test. And where's the liver located? Which quadrant? Right upper quadrant. Okay. So you take your fingers like this, like a hook almost, and you put them under her rib cage. Take a deep breath, and you put put your fingers under a hook and exhale, and you see if you can feel the edges of that liver, okay? And if you can, then that's not a good thing, okay? Right. So what else can we do in terms of her abdomen? We can percuss, right? So when we percuss, we're going to percuss all over her abdomen. I showed you how to do percussion already. The normal sound that you should hear for the abdomen should be something we call tympanic. Tympanic. Like timpani. What is timpani? Like a drum. Like a drum. Does that make sense? It sounds very hollow. Because there's a lot of, remember, there's a lot of gas in there. That's normal. What if we're percussing and it changes from that tympanic hollow sound to something that is much more dull? Could indicate that there's an obstruction, fluid, a mass. Something's not right there, okay? So that's why you percuss.
Couldn't it just be like fecal matter?
It could, but it could be obstruction. You know, elderly people, the number one cause of an obstruction is fecal matter because they're dehydrated. Okay, what else about the GI system should I be ascertaining?
Asking them about their last bowel movement.
When did you last have a bowel movement? You know, you'd want to know what the color of it is, the consistency. Okay. We can also, while we're here, talk about genitourinary. They have a Foley catheter. We should be looking at their urine. If they're urinating, we should be looking at their urine. What the
They have
color
something
is,
the size of a basketball in there.
Right.
It could be a full bladder too.
Yeah, it could be a full bladder. Yeah, they may have suprapubic distension. Right. Okay. Let's go on to the extremities. And let's start with the pulses. Okay. We've already done the carotid, so everybody show me where your brachial pulse is. So we have brachial, okay, and then radial, okay, and then we go to femoral, right? Femoral. And then what about popliteal? Popliteal, okay. What about the DP pulse? Okay. Now this one I want to see. Everybody show me the PT pulse. PT pulse. You guys show me your pulse. Show me your pulse. You don't. If you don't know, that's fine. Okay, that's why I'm doing this.
I don't know.
Okay, the reason I'm doing this is because I had a nurse not so long ago who told me that the PT pulse was right here. Not right. Okay. Everybody feel. Okay. You have a lateral malleolus. What is a malleolus? That's that little knot, that little bone tuberosity right here. You have a lateral malleolus. You also have a medial malleolus. That's right here, medially. The posterior tibialis, as the name tells you, is behind that medial malleolus. So everybody find that for me, please. So locate it medially, right here, and palpate it. You should feel it. You're all young and healthy, so you should be able to feel it. Be careful about that because a lot of people have trouble with that for some reason. Everybody's found it? Are you all alive? No? Can't find it? My hands are cold. Blood pressure. What if you can't find a pulse? Do we say it's
Unable to
absent?
palpate?
Doppler. You have to use the Doppler. If you cannot palpate the pulse, you need to use a Doppler.
And then
Okay.
you look at the color and everything as well.
Absolutely. Okay. So there's the pulse. Now, let's also look at her hands, her fingers, okay? And there's 3 C's that you need to be assessing on the fingers. You need to be assessing for cyanosis, capillary refill. What's a normal cap refill? Less than 3 seconds, okay? And something else called clubbing. You heard clubbing, finger clubbing. Okay. That's where the angle, this angle right here with the nail and your finger should be, you know, roughly less than 160, somewhere around in that. If it's over 180, that's considered clubbing. An easier way to remember this is people who have clubbing of the fingers, that distal part of that finger will be larger than the proximal part. It looks like a baseball club, okay? Just like a baseball What does that signify? Clubbing. Chronic hypoxemia. Chronic hypoxemia, okay? You may see it in somebody who's a COPD, for instance, okay? All right, now, this should be pretty easy. I'm going to actually assess musculoskeletal assessment. So I'm going to assess her range of motion and her muscle strength, okay? So how do we do that? How have you guys been doing this? So let's do her upper arms. So I'd have her, let's go through all the joints. So how do we do this, okay? And I like to have my patient hold out their arms like this to see if they can keep it like that. Can't tell you how many times I've had a patient who did this number here and it was a CVA. New onset CVA, okay? So have them do that. I always encourage you to get range of motion through all the joints. You're doing this, okay? Okay. I also have them squeeze my cold hands. Tight as you can, tight as you can. Good, okay? You're strong. What should we know with their grips? They should be equal, okay? They should be equal unless somebody's, has a weakness on that side or they've had a CVA, okay? So they should be equal, okay? Muscle strength. What about muscle strength? You have them, she's going to go up against resistance, down against resistance, those sorts of things, okay? We're going to do the same thing on the lower extremities. And as we're doing the extremities, we're looking for discoloration, edema, those sorts of things. We're going to look at the cap refill on her toes, okay? Those sorts of things. Now, the last thing we do is the integumentary system. We're almost at the end here. The integumentary system. Let's assume this person is bedridden. She's 85. She's had a CVA. She has contractures, and she can't turn. What's going to be important to assess? Turn her over. Turn her over. Look at all of the bony prominences. The scapula, the sacrum. The heels are notorious for having breakdown. Make sure that you got something like that, you want to lift those heels up and look at them. Make sure they're not starting to develop any breakdown. And that means simply is non-blanchable erythema. They're starting to have non-blanchable erythema, then that's an indication they may be
You can't see
developing
the
stage 1.
heels well. Since it's hard to get down like that, they have little mirrors that are just tiny that you can use just to put underneath too. They'll go with compact or something like that.
Okay.
Easier sometimes to see.
It's a good idea. Because save your backs.
Yeah, because a big leg can be heavy to try to, and then plus the lighting's not good because it's coming from above instead of from below.
Yeah. So remember, if you've got somebody who's really, immobile or doesn't have really good movement, you need to assess those areas to make sure that there's not skin breakdown. It's very important, especially in the elderly population. Okay, that's it with the assessment.